a lot of the time in our jobs and in healthcare generally, you ask people, what do you think is going on? They say, oh, I don't know. From my experience, people coming in with some form of HSD, heads, anything on the spectrum, actually, they'll turn around to us and say, well, I think it's this, or it might be this. Or especially if they've joined up the dots, they've had multiple stuff in the past and they get to this point. This is only my experience, but again, I realise you're in a specialist situation. They're coming to you potentially already suspicious. But from your own, I guess, your own experience and from what you see, do they have a more idea about what's going on compared to other patient groups?
Completely.
Yeah.
I mean, the whole diagnostic odyssey, isn't it, is 10 to 15 years. That's the average for these individuals to get diagnosed. I mean, we see the whole end of the spectrum
Mm.
as well of ages, Ben. So we do see pediatrics right through. Um, but I often don't address that straight away. So when they come in to see me, we often see sort of your two groups coming in, your ones that are wanting a diagnosis to try
Yeah.
and, or an indicator of if they think they are. And then those that have been diagnosed and are now looking for some kind of management. Because unfortunately, as well, as you probably well know,
Yeah.
even if they have been diagnosed, it's diagnosis and off you trot.
A lot of the
There's no
time.
specialist centres or care, and we often, which is really unfortunate, see it time and time again. I went for physio and it made me 100 times worse. I never went back.
Mm.
And I think that is because the narrative around hypermobility is still, we still aren't teaching it at undergrad. And I've just seen that with the students. They hadn't even heard of hypermobility,
Really?
your symptomatic hypermobility. They just thought it was great if you could touch your toes. And I
Mm.
mean, I did when I came out of university. When people
Yeah.
used to say, can you touch your toes? No, I can't. Oh gosh, that's unfortunate. Now it's like, oh, thank goodness you can't touch your toes. Um,
Yeah.
but they come in and I try not to address it straight away, it'll be what have you come for, etc. But you can guarantee they will know a lot about it because they've been passed from pillar to post.
Yeah.
They've been on this huge journey of multiple healthcare providers and they've had to search it out for themselves and look into it. And often, though, they will say, I've looked at the criterion,
Mm.
but I don't know. I don't know if I do. I just, and what's really sad, Ben, and we've started to really see this, they're gaslighting themselves.
Go on. Tell me more.
So, because they've had so much gaslighting, and it comes from family as well, it's in your head this, you're anxious.
Mm.
It does affect women more. We've just done a study, 95% again more women, backing up the other
Yeah.
studies with demographics. They'll, they come in, they'll they'll sort of, well, they'll say, I don't believe it. You come to your diagnosis and you'll say, we've gone through the criterion. You tick the boxes, and I go through it all thoroughly with them. I discuss it with them. I discuss the 2017 classification. Some are familiar with it, and they will often say, I didn't believe that you would tell me that because I always doubt myself.
Mm.
So they start to gaslight themselves. So, perfect instance, bladder issues, women, been going all their lives, whether it be urgency, leakage, connective tissue, isn't it? And yet they will still say, well, all women have that. All women do it. I've been told it's just women do that.
Mm. It's part of life, isn't it? Yeah.
Yes. Yeah. And they honestly start to gaslight themselves. And they say that. They say, I don't trust my own judgment. And that's really sad.
Yeah. Yeah. And you said from children as well, right? So is there a minimum age for
So you
either?
can't, yeah, so you can't diagnose pediatrics HEDS. It's the pediatric HSD classification. So once they hit 18, but what we always do say is phenotypically they can tip into it once they're 18. If there's a strong family history of it,
Mm,
parents have already got diagnosed, but we'll see children often. So we see pediatrics sometimes parents will bring them in just to see for symptomatic hypermobility, and they are showing it, unfortunately. I had one in the other day, wasn't, and it was
mm,
great. I said, "You've caught him. He's a boy. He's probably going to just start to come out, but you've detected it. You now need to help him with his strength training." He did loads of football. I said, "Help him with his strength, get him going." And actually, I think phenotypically he'll go the other
mm,
way. Yeah,
mm,
he won't. He'll, especially if his mum starts encouraging that strength alongside the football. But of course you can't diagnose them HEDS because of the criterion.
mm.
So often, 5, they're not going to have scar tissue. They're not going to have any prolapses, hopefully, things like that. But then we do see some pediatrics where there has been a lot of colorectal
Really?
gastric issues, and they're getting told at a young age it's all down to anxiety, just get them on Movicol.
Mm. Doesn't help at all.
No,
And
no,
do parents push for it? I don't treat kids, to be clear, but
I wouldn't say they push for it. They're concerned
concerned. Okay.
because of their own experiences often
Mm,
of being completely not understood, and they don't want that diagnostic journey that they've had.
yeah.
They certainly don't push for it. I think they just want that recognition. And like we keep saying, the validation is much better than disbelief and disregard. And particularly with children, Ben, you know, from my own experiences, and I'm really passionate about that, I was from a very young age just told, stop. I would go over on my ankles all the time. I had growing pains. My kneecaps would go. I had lots of bladder issues and diet and gastric issues. I was just labeled anxious,
Mm,
You get into your teens, oh, could be depression setting in, all that. So I'm really passionate about that, overactive bladder. Oh, it's just she's a bit anxious. So when I have young girls coming in with that are wetting themselves in their in their 12, 13, can't keep dry, I'm really passionate about getting them into urogynecology and getting them looked at, because we shouldn't be treating people like that.
can it go the other way with parents? Can it be, especially if the parents haven't been through, or especially themselves just kind of dismissed it or had the same experience, if they're, I say dismissing it necessarily, but not putting the pieces together or thinking again, it's just anxiety, depression, and not something bigger. Uh, can it go that way as well? Yes.
We've seen that as well, Ben, where parents have just, in the end, they've had a friend or a relative. Like I've had a few where the grands have come as well and said, "Look, I really think we need to get this child looked at." Or a friend has said, "Just go and see Anna."
Mm,
And they've come in with a very sporty individual that's really starting to suffer with fatigue issues, having to drop out of sport because of recurrent injuries, gastric issues, sick easy, allergies, bladder, bowel. And then the parents have been pushing, 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 saying, "Oh, well, the doctor said you're okay. It's all in your head." And then
yeah.
we turn around and say, "The symptomatic hypermobility here. It's great." And I always soften it though. It's
Mm,
great you've caught it. Because
yeah.
the research,
Ah.
as I say, the research shows catch them young and you can make massive differences to their outcomes. Huge differences. I tell you, I feel sometimes the hardest patients I see
Mm.
are those coming in. I had one a couple of weeks ago, 60s, 70s,
Ooh, okay.
that have just been diagnosed or are wondering if it could be. And they literally have had a lifetime of mental health issues. And I
Mm.
find that incredibly sad because even families, they've gone through, say, divorces or they've had failed relationships. And, you'll often find these as well, neurodivergences playing into this. They haven't been able to
Yeah.
maintain relationships. And I find it heartbreaking.
So usually people, my understanding, and tell me if I'm wrong, as if we have hypermobility as we get older, we're supposed to get stiffer.
Yeah,
Is that right?
yeah.
But the pattern may be there from earlier years, even if we're not there, even if we've seen them in the 40s, 50s. Um, but they may say, "Oh, I'd had in my 20s or late teens, I had the party tricks, or I could do the splits and all the other stuff." Um, is it if they say what if we've got someone, and we'll come to the diagnosing bit in a bit, but if someone, I don't know, 20s, 30s, and they say what will happen as I get older, I often tell people, well, usually you become a bit less hypermobile, and a bit more. Is that right?
Joint wise, but it's
Yeah.
not just about the joints, is
No,
it?
it's true. No,
That's
no.
what's so hard. So you'll often find, which is again quite sad with it, that your hypermobiles will have become really arthritic. So, they'll have started to be told in their 20s and 30s they've got an arthritic spine, hand joints going, hips going, you from that other course, labral tears,
Mm,
loads of joint issues. So then, yeah, they do start to stiffen up. But what we do tend to find, and we don't know, again, there's no research,
mm,
very little, particularly with very little research into why it affects women more. Um, Perimenopause, menopause. And when that occurs, we often find it's the comorbidities ramp up, Ben.
mm,
So actually, some ladies in the, particularly that's where we've noticed in that multidisciplinary team for the CCIs, the upper cervical instabilities, you do tend to find quite a lot of the hEDSs, HSDs have tipped into neck instability in the perimenopause, menopausal years.
yeah, yeah. As the
Yeah,
hormones change and as things.
hormones. We think
Mm,
it's the hormones
all right.
that are changing. So that's why you get your pubertal girls, pregnancy can create shifts at times,
Yeah.
and then perimenopause, menopause. So you might tend to find, yeah, that the joints stiffen up,
Mm,
but the comorbidities can sometimes start to ramp up.
absolutely. Yeah. Especially I'm thinking of the bowel stuff. Um, I mean, we said about POTS that you mentioned POTS earlier. Um, is it, can you get it without, on its own, like without hypermobility, or is it almost like a telltale sign in a way?
Do you know, Ben? Yeah, you can. It's really fascinating because one of my PhD friends that I met through uni, she's a cardiac nurse. She's completed hers
Mm.
PhD, so she's a doctor now in it. She did it on self-management for POTS. Now it's fascinating because her whole study was just POTS, but then what she started to see by doing the work was most of her POTS patients, she started to open her eyes to the fact that the hypermobility was there.
Ah,
But yeah, you can get POTS, can't you? And you often see POTS coming post-viral. But then again, look at the studies that have been done on your long COVIDs.
yeah.
50%
Are POTS really?
hypermobile, hypermobiles.
Are they?
Yeah. And
Ah,
some have catastrophically tipped into it. So
mm,
have been asymptomatic,
yeah.
but then tipped into.
Interesting. Okay. Oh, I didn't know that. Was there out of, was there with an age? I want to say, was it more leaning towards the younger people with the long COVID? If half are hypermobile, does that mean more younger people having long COVID?
I've not looked at the study completely,
Um,
Ben, so I couldn't completely comment on it. I just know that they've said there's a few studies now that within long COVID, you will find a lot of hypermobiles have got long COVID and it's the
yeah.
tipping. But then again, we've seen this before COVID, where hypermobiles, their symptoms, whether it be their joints, the laxity, or the comorbidities and the other tissues, sorry, ramp up after illness,
Mm. Yeah.
whether
And
it
then
be any virus or you get this ramping up of the symptoms. And your orthostatic intolerance, your POTS, your dysautonomia, I do think I see a lot of my patients where they are doing really well, get a virus, and you think, oh no, because
mm,
they're going to come back in at square one again.
I send them far back. Just how we can't separate it, can we? Because the connective tissue affects so many parts of the body.
Yeah.
Uh, any whether it's immune in that case, or whether it's other stuff, um, can easily set them back. Agree. Let me ask you: we got this person who's come in to see you. They've been referred, let's say, and they're a bit dubious. They weren't sure. And to use what you said earlier, if they thought themselves they were making it all up in their own heads. Uh, you go through the criteria with them. They fulfill whether it's heads or whether it's at least HSD, uh, and they feel validated. But they say, "What's that? Where should we start?" We've got someone who's got been given the label, but they don't know what it means.
As in they've never looked into it, Ben.
And
They
let's
they
let's
don't.
let's assume that there's a small chance, small percentage of people who
It's
haven't looked
not
into it.
come along. So I always explain it. Obviously, it depends where they are on that spectrum, but I always explain it that hypermobility is not just about touching your toes.
Mm,
So it's multisystemic. It's any areas you've got connective tissue throughout your body. It's what holds you together, and yours is not holding you together as it should be. So it's your guts, it's your bladder, it's your bowels, it's your heart. And I always say as well, none of this is life-threatening.
mm,
It's just literally a pain in
yeah.
the only good thing with it, and I always say this to them, the only good thing is you don't look old as you get aged. You've got
No.
lovely skin. You'll always have quite a youthful appearance, which they do, that smooth skin.
Mm,
So I'll always explain it as that, and which immediately you can see them sort of, I mean, tears, Ben. We
yeah.
have tissues on our desks. I don't know any of mine that don't come in with relatives as well, and the whole room bursts into tears because it's that validation and oh, that explains that, all my headaches I've had my whole life, my temperature regulation issues, all of these things are becoming more and more recognized in the research as well.
Yeah.
Um, so I'll explain it's all the systems, it's not just about the joints. I'll say it isn't life-threatening. We need to start to manage it. And by
Mm,
managing it, we need to work together. We need to get what you want to achieve in your life. And I always say it is a spectrum.
yeah.
So what you want to achieve might not be what my lady before or my gentleman before had. It's got to be what you want to achieve, and we have to work together, else it's never going to work. And then I talk about we're going to get a toolbox together. And within that toolbox is everything you will need to try and
Mm,
allow you to function to what you want to do. And because, Benny, you've got that huge spectrum, we've got some that are bedbound,
yeah.
that want to just be able to sit up and enjoy a conversation with partner, family, friends. We've got some that want to be able to go and walk around the block. We've got some that are, performing CrossFit, going to the gym. So that toolbox is very dependent on what that patient is, but they have to understand as well. And I do make it very clear, this is lifelong. You have what we call an issue with your tissue. You have a heritable connective tissue disorder. It's real. It's there.
Mm.
Um, but we need to start to manage it. And I always say as well, and we can manage it, and we can get the right care for you, and we can get on top of this, and we can just start to just try and keep you functioning.
Yeah. Yeah, there's hope, as you say. Because if they've been through, I guess purely from my own experience, if someone's been through multiple appointments and getting nowhere and all the tests and stuff, and again, vast majority probably have looked at themselves and come to a conclusion. But sometimes if we find out, oh, I've got this inheritable condition that, from my genes that can't be reversed, well, it can be sound a bit doom and gloom, can't it? But actually, well, we've
It's how
both
you
seen it.
phrase it, isn't it? It's
Yeah,
how you talk to them about it and you
yeah,
empower them.
yeah,
And I say that you're going to take control of this again.
yeah,
And yeah, you are going to have blips. It's known boom and bust cycles with hypermobility,
yeah.
but you're going to learn that that's all right, that you're going to get back up. You'll be okay. It's learning to manage that. And
Mm,
you can manage it. Um, and it's like I said, Ben, it isn't actually rocket science to treat these individuals. You've got to just have that awareness and compassion, listen,
yeah.
and do your basics. And I also say it as well, your hypermobiles know their bodies better than anybody
Mm,
because they've lived in it. And for a hypermobile, it's the weirdest thing, and I can vouch for this. You know every single bit of your body. You're aware of it all the time. You're just aware of your joints, you're aware of your internal stuff going on, you're aware of your heart, you're aware because it's beating slightly, all these things. So you've lived in it. So I always say to them when we're doing exercises together, if you don't like something, you let me know because we'll find an alternative.
yeah,
And that empowers them actually. It's not pandering to their needs or
yeah,
you're empowering them.
yeah. Do you think, again, purely from my experience, when you ask the question of what did you kind of expect or want, and then again, most just come in either with the diagnosis or suspecting they have it. They'll say about, oh, exercise to help my hypermobility or heads. Is it a hard sell anymore? Do you think most of them, from my experience, that's what they expect. I realise being physio, they come to us probably expecting that because we are physios. Um, do, have most, from your experience, kind of bought into that before we've even said it?
They know it is,
Hmm.
but they also know it's a very fine line
Yeah.
because of past experiences, Ben,
Yeah.
a
Yeah.
lot of the time
Yeah.
where
Yeah.
they've been pushed and fatigue, because a lot of them have got ME/CFS or
Yeah.
chronic fatigue. They've POTS, dysautonomia plays into it. Um, so that they come sometimes I get them coming in quite apprehensive.
Hmm.
They come as a new patient and you can physically see them thinking, oh, what's this going to be like? Oh, she's going to just give me loads of exercises. And I always actually say, do not worry when I come to the treatment side of it. This is not going to be your typical physio appointment that you've probably had in the
Yeah.
past. This is going to be very different. I might only give you 2 or 3 exercises to do, tiny little increments,
Yeah.
and we'll just see how you go. And we'll introduce them, and they're the ones that do the best because I see them over years just gradually doing it nicely, and they just start to pick up. There's no rushing them, particularly the young
Hmm.
ones coming in. Just target it, really functional stuff they enjoy doing.
Hmm.
Get them to tap in on that. And no, you normally find that they'll come into the exercising, but they come in with a lot of apprehension
One thing
because
I've,
they're
oh,
just so worried about injuring
yeah,
as well.
from their own past experience of like doing PE or playing with their mates and they've happened to then roll the ankle or fall over or something happens,
Yeah,
that then will naturally put anyone off. That's human nature not to want to do the thing that gave you an injury, isn't it?
exactly. And this is what it's interesting that, Ben, because in my PhD, we've been talking obviously about the fear avoidance model, and that's huge for this
Mm.
patient population. But they don't like you saying fear
Ah,
avoidance because they don't say it's they're avoiding it or fear. It's not, but I think it's getting your terminology correct when you're
Mm.
saying to them, because I think they feel like you're on the attack when you sort of say that it's not a genuine, fear is not a genuine process. Do you know what I mean?
Yeah.
It's a personal process that oh, I don't want to do that. I don't, it's not that. It's a genuine, I do that and
Mm.
I injure. And in fact, we ran on our patient public involvement group, Ben, and it was fascinating. One of them said, and then they all agreed, I've stopped going to A&E when I dislocate or when I
Yeah.
cause an injury.
I've heard that. Yeah.
And they said, I've just stopped going because it just became too traumatic. Because every time I go, I just get told that it's back in place or that could not have happened. No joint
Mm.
can do that, off your trot. And then some of them said, which really alarmed me. So that's why I don't go out and do any exercising. Because if I exercise or go out my house
Yeah.
and I injure, I have nowhere to go. So I don't do anything because if I do and I injure, I've got nowhere to go.
Mm.
And I
So what do you
thought,
say?
wow. Well, that's for me, that's where I wanted to do my research as well, Ben, because that's about, with individuals as well, the use of supports for your hypermobiles. It works.
Mm.
Compression, defo, they work
Yeah.
with select patients, and this is what the research is coming out with. Um, but that sense of stability it gives them, they feel like they can go and do some functioning without the risk of injury.
Tell me about that conversation because that's something I became more aware of in the job I'm in now. And we see, I think in our pain service, you see of all the services, but the most likely to see people with hypermobility or somewhere on the spectrum, as you say. And it was only when one of the patients happened to be going through orthotics and they mentioned about Lycra suit, and I went, what is this? What, at first, what are you doing in orthotics? B, what is this Lycra suit thing? And then they came in and said, oh, this is great. This is, I can do things that I'd never heard of it. But now, every time we get someone with hypermobility, we'll, provided they haven't had it already, do the referral and they can go have the
Brilliant.
discussion. Because and this is just personal experience, seen it with some people where it helps them, whether it's feel more confident or just able to do a bit more. Yes, it doesn't stop them, you know, completely dislocating. It still
No.
can happen. But often I'll suggest it and patients go, eh? What are you on about? So, I mean, I can tell them that, but how have you found trying to have that, I'm going to say selling is not the right word, but a discussion about whether it's the compression or lycra suits with them?
So I will always start. I can't discuss it too much because our results, we're looking at getting the study published. But this survey that we've done, Ben, we had 1,517
Wow.
respondents. It's a brilliant survey. Um, a tiny number of that whole total had used a defo,
Really?
but that was a tiny number because of lack of awareness in the majority. They hadn't been told, but the willingness
Mm,
and the how come no one's discussed this with me was phenomenal
mm,
in the respondents that hadn't tried it. Why is no one? Oh my goodness, I could just imagine that would feel. So what I always do with my patients, and it's just what you said there, it's brilliant to hear other physios talking about the use of the defo and compression.
mm.
I'll always say when we start to talk about the toolbox, hip say, have you used any compression garments before? No. So you start to explore, don't spend a lot of money. I want you to go and just because we've noticed as well there's a lot of gatekeeping going in up here in Leeds where we can't get them into orthotics and that
Oh,
needs to change. So we have some people are getting referred into orthotics and some are just flatly, no, you're not going. This needs to change and hopefully our study is going to
yeah, yeah, yeah.
create a bit of change with it because we've got really good, valuable data. But I'll always say, don't spend a lot. Please don't spend a lot. Go and get into just some either compressive leggings, compressive shorts, downsize,
Yeah.
vest top. I'll show them some sort of different types. I'll also suggest K-tape. They love it. So if I get them
Mm,
in the K-tape plus a compression garment, 9 times out of 10, Ben, they'll come back in at the next time I review them and go, that's been life-changing for me. I was out walking the dog the other day. I've been able to do X, Y, and Z. So then you think, brilliant, right now I'm going to start getting you doing your exercising as well.
yeah. People often assume orthotics is like insoles and
Yeah.
I don't know, amputee stuff. Uh, but they do these other things as well. I
And
don't know a
what's
whole lot more.
fascinating, Ben, and I find it really fascinating, is also so many of mine go, oh, that's why I like swimming in a wetsuit. I've always
Ah.
said I wish I could just wear my wetsuit around and about, or they'll say something, or they'll come in and they've got gym leggings on. And you're like,
Mm,
do you like comfort? Oh, oh, I hadn't thought of it like that. Yeah, I do quite. The only thing is, Ben, you do have your sensory issues sometimes in
right.
some of the population with the
Yes, yes,
neurodivergence, and they
yes.
don't like that tightness. So in that instance, we might K-tape just to try and get that joint. But then the K-tape, you've got the mast cell activation and the allergies.
Okay. Is there an alternative type of clothing that's still tight but isn't like a legging or the equivalent?
We're trying to look into all of this. And again, I mean, DMO, defo is totally different because you've got the bespoke paneling in it.
Yeah.
And there's a couple of brands on the market for it. Uh, it's expensive though, Ben, as well. That's the other thing. So really, we need them to be able to access it.
And
And they
so,
also need a few pairs. You can't just give them one pair. Some of them are in
mm,
it a lot.
but while they wait, you say one size down on whatever the
Yeah,
garment is.
yeah. Don't spend, I always say to them, don't spend a lot. Just
Yeah.
get yourself one size down in something, a compressor. And nowadays, if you think, you can get so many of these on like Amazon and the internet, because athletes all wear them, don't they?
Yeah.
They love
Yeah.
their compression.
Yeah. Yeah. Watch any major sport team, they'll have their compression garment underneath their
Yeah,
uniform, whatever it
they
is.
will. You're right. They have the compression, so they can get a hold of them quite easily.
Mm,
And I just say downsize.
mm.
Um, the ones that you can't do that for are sort of your finger joints, and we get a lot of you see, that's where you notice it with the children. They'll have been told that difficulty with handwriting, lazy, but they're getting
Ah.
classed as lazy because they can't hold their pens or pencils.
Mm. Because the fingers don't work
Yeah.
properly.
So that'll be
Mm.
painful. They're shaking their hands all the time because or they can't cut their food correctly. So the parents are still cutting food for them.
Interesting.
But we do ring splints for those.
Okay.
And you can get quite nice ring splints actually. Just silver ring splints. So a lot of mine have them on as like jewelry. And that's brilliant because it stabilizes the
Jewelry.
fingers. Yeah.
Mm.
Oval 8, ring splints. Stabilizes the fingers. And then you're gonna try and stop that early onset of arthritis, particularly in younger girls.
So it's splinting, exercise, garments. When they ask about, and again, I realise this will vary depending on the person, their own individual needs, their own individual goals. Um, whenever they say, well, what do I do about anything else? That's kind of the pillar you have for if they say, what do we do about this in the management side of things?
Yeah, we will often, I will always get them to come, especially new ones with a family member,
Mm.
to get the family member on board as well, to
Mm.
listen to the exercises, to help them with it, to motivate, to coach them as well from a family point of view,
Yeah.
or, husband, wives, whatever coming in, partners. I don't, I'm not as keen actually when someone comes on their own. I'm always like, oh, I prefer it because then they've got that double edge of someone else. I can show how to K-tape.
Yeah.
I can show techniques for them. The other thing we do at the clinic, Ben, is we do a lot of hands-on. acupuncture. Acupuncture works brilliantly for them. But this is not we're seeing them once a week, Ben. These people we're often seeing once a month, every couple of months. Some, because they've traveled, will
Yeah.
just come and see us every few months. But those that live a bit closer will come for sort of the maintenance, and they do really feel that they never go back into a full dip. They maintain quite a nice level of function.
Okay. Mm. When I was thinking about our conversation beforehand, one of the hardest parts when discussions I've either heard about or witnessed is where someone has looked it up, they've gone through the criteria, they think they're hoping that they fulfill it, and they sit down in front of said clinician, or this is for heads, they sit down, the clinician goes through it with them, and on the day, for whatever reason, they don't quite fulfill it. Um, and that for some people can be very disheartening, invalidating, difficult. And they don't, they're hoping for more than just the HSD. They're hoping for the full-on hEDS diagnosis. Maybe that gives them more validation. But they still have I always tell them that you still have this legitimate issue here with the
Yeah.
HSD. But what would you say if you've got someone who's very upset that they haven't quite fulfilled the hEDS criteria, but obviously still struggling?
Yeah.
Um,
I
maybe,
think that's brilliant. It's such a hot topic, this as well at the moment, Ben, because you know the 2017 classification is getting changed in 2026.
2026. Oh, next year. Okay.
Yeah, next year, Ben. So the journey
Mm,
to 2026 is on its way now. So from 2017 to 2026, the international consortium
mm,
have been really, there was a huge Delphi done of
right.
loads of clinicians and trying to get, so there's a lot of talk about what's going to happen in this new criterion. I always say to my patient, because you can see the face sort of fall a bit,
Mm,
because they desperately think that hEDS is the pinnacle of hypermobility and that they
yeah.
need to be that and not HSD.
Yeah. Yeah.
Hypermobile spectrum is just being bendy. That's it.
Yeah.
The thing is now, and even in my research, so my research right from day dot, and that was 3 years ago, in my thesis,
Yeah.
it is classed as HEDS stroke HSD. It's symptomatic hypermobility. So when I say to my patients, look, I sit them down with the 2017 classification, I go through it bit by bit, I mark them all, I show them exactly, and then I'll come to it and I might say, so from this criterion, it's saying you're HSD. But in all honesty, that spectrum as a clinician and a
Mm,
researcher is really blurred.
yeah.
And I was only talking to Dr. Anne McCarthy this morning about it, the other physio down in London. I have patients that are diagnosed HSD, but have colorectal issues, major prolapses, never had children. I've always had issues with that, but I've not fitted the joint criteria for hEDS.
Ah,
Or they haven't got the scar tissue, but they've got really soft, doughy skin, and I think I always just explain, look, it's a spectrum
yeah. Yeah.
and it's symptomatic hypermobility, whether we call it HSD or hEDS, and you have got symptomatic hypermobility. And currently on the 2017 classification, which is about to change in 2026, you would be HSD,
Mm,
or currently you are hEDS.
yeah. Can you say what's going to change, or do we even know what's going to change yet?
There's talk, Ben, about this. Because if you go on like the Ehlos-Danlos Society and look at HSD and hEDS, there's very little. You
Mm,
can't actually. And the most current research coming out has shown the comorbidities are the same. They have one study has reported that hEDSs get more subluxations or dislocations and have more colorectal issues.
Okay.
Prolapses, major prolapses. So
Yeah.
they had noticed that in a large survey population that the hEDS has reported that more. Um, I think they'll also bring in the comorbidities,
Mm.
but then that makes it quite difficult because what happens if how would we diagnose as physios the comorbidities
You'd have
unless
to
they
rely on
already had?
exactly. Yeah.
And who are we going to refer to? So if I've got someone
Yeah.
in that I suspect is gastroparesis, who am I going to refer them to? I can't
Yeah.
even refer them to, so they're not going to meet the criterion.
Not unless they've been through those, yeah, hoops, hoops with
Exactly.
hoops.
Hoops with
Yes.
hoops. Yeah.
Yeah.
So it'll be fascinating to see when it comes out. I do hope there is more recognition of symptomatic hypermobility and you're
Yeah.
somewhere on that spectrum.
Yeah. Yeah. Like we have for other conditions, right? Like whether it's fibro, whether it's, I'm going to say what you said about neurodiversity as well, also on a spectrum.
Exactly, Ben.
Range of things on a spectrum. Interestingly, those things all get the same label. You're just on a spectrum of it. This is once you get to a certain point, you get
Yeah,
get
and
an
I
extra
don't
letter
think
in it.
yeah, exactly. And I don't think that should exist. I think you're spot on. Look how with the neurodivergence with autism, they took away Asperger's, didn't they? So that doesn't
Mm,
exist anymore. And I don't think it should. You're on that spectrum, aren't you? A
mm,
neurodivergence, and it's all those dyscalculia, dyslexia, ADHD, or DHD, ASD. They're all in that one spectrum. And I think hypermobility, symptomatic, is a spectrum.
yeah. But yeah. Anything else for the future? I want to ask this at the end, but as we're on the subject now, you said about they're going to look into the so criteria is going to get updated next year. Um, we'll see what comes of that.
I think it's really exciting actually. I can remember when I first started my journey, Ben, with my supervisory team, and two of them are big in hypermobility. And they said it's a really exciting time for you, this Anna, to be
Mm,
involved in this because it's going to expand. And I've noticed in the 3 years I've been doing this part time, but 3 years, how much more research is coming out. Like a lot and good
mm,
research. I think for the future, though, we have to start, and I know it's been important and still is very important to work out exactly what's going on. We have to do that, but the management of it is a priority.
mm,
Research. So, like, our study that well, my study that I'm doing, there needs to be a lot more research into the management of it and effective management because it isn't just about exercising. It
no,
isn't. It's got to be a real holistic, multidisciplinary team, you know, psychotherapy, hypnotherapy we use a lot with ours because there's been a lot of trauma for them.
yeah,
There's a lot of trauma. Um, And then I think as well with the research, we have to work out or start to do more research. And I'm not trying to get on I'm saying it just because I'm a woman, but we do have to look into why is it affecting women more? Look into the hormonal links or what's happening here that is causing it to be such a huge
yeah,
disparity.
yeah.
Um, but then, the research on women with medicine is lacking, and maybe there is an
Yeah,
argument then, is that why it's been neglected for so long? Because it's been put down to anxiety and hysteria.
yeah. I mean, look at how much we talk about menopause and endometriosis now. Compare
A-
that to a decade ago.
Absolutely. I know. I sort of look back at my mum and things and think, gosh, they just swept it under the carpet.
Yeah, yeah. Mental health now is talk so much more about it. And again, compare that to a decade ago. You didn't want to talk about it, or
No, no.
you know how much we talk about we were talking about neurodivergence earlier.
Yeah.
Yeah,
And I don't think, people have said that to me. That's a good point. It's the same with the neurodivergence, isn't it? Said, oh, it's just this trendy thing, everyone's jumping on it, It's not. It's because people are starting to talk about it. And it's the same with hypermobility. There's an
Mm,
awareness now, and people are talking about it. And more medics are coming through, younger medics starting to think, all right, okay, there is stuff going on here for these individuals.
mm,
You know, like these surgeons we've been working with, it's brilliant to work with some of these surgeons that are actually saying the narrative I've been told cannot be someone making it up because it's the same narrative every time these patients come in.
mm.
And
Do they
it's
come?
great that surgeons are recognizing that.
Yeah, yeah. You don't. Certainly, the risks, as we were discussing before we hit record, the risks of, whether it's scarring or healing times or other stuff after surgery for someone who's hypermobile, especially if they're on a one certain end of the spectrum where they're particularly hypermobile, you know,
Delayed healing,
yeah,
risks. I mean, you've got your anesthetic risks,
yeah,
medication risks. You put MCAS, POTS into all of that. Post-surgical, pre-surgical procedures has to be handled by teams that know what they're doing.
yeah, which there isn't many of, and for some areas, dare I say, not at all. Um,
I know, and that's when you see the really bad outcomes coming through. We had a girl, she was a few years ago, she was only 19, and she'd had a labral tear. She was a dancer, never been diagnosed, wasn't diagnosed,
mm,
and it wasn't great outcomes. And within a year, it had bilateral hip replacements. Uh,
19.
Yeah, yeah.
Ooh,
I mean, it was just disastrous, Ben. I've got another girl at the moment. She's a strength and conditioning coach, and this is what makes me laugh about, it's you've got to just get them strong. No, she has muscles on muscles.
mm,
She knows exactly what she's doing. She's been through I mean, she works for an elite team here over in Leeds. She's done protocols. She had her, she had a shoulder stabilization. Didn't know she was heads. I don't know what. I think just the vulnerability of the tissue. I don't know. She cannot now keep that joint in place. It just hangs.
mm,
She has to physically, she's 22. She has to walk around holding her arm. Nothing holds it in place, not even the compression,
no,
nothing. So they're talking about probably fixating it.
oof, 22. It can go very wrong, can't it? If you don't, if you,
It can if it's not. Yeah, yeah.
yeah,
And that's why I was saying in Cambridge, just if you have any suspicion, I know people say why I get asked it. Why are you diagnosing these patients? Why are you diagnosing them? Because validation,
mm,
disbelief, disregard, mental health issues in the long run, but also you can massively influence outcomes of treatments if you know that they've got symptomatic hypermobility.
yeah, yeah. Is out of interest, is it in any other parts of the world, is it any better at identifying and managing?
Uh, I think I think we're one of the better countries.
Really?
I know my supervisor, one of my supervisors, Benham Lycra, he's in Denmark,
Mm,
and I think they don't even really they'll recognize hypermobile spectrum, but they're not keen. I think there's a lot of countries. I mean, I used to sit on EDS Echo, so that was with the Ehlos-Danlos Society,
yeah,
and they had clinicians from all over the world. And I mean, it was pretty much the same story, Ben.
really? Okay. This isn't just
And
well,
actually, when we did our survey, it was only in the UK, but the Ehlos-Danlos Society launched it for us on their platforms. And we had so many emails, private messages coming from country all over the world saying, why aren't we getting resources like this? Why haven't we been made aware? I need to be involved in
Mhm.
trials like this.
Interesting. Even in other, bigger,
Oh, this was
countries and
Australia,
things.
America,
Really?
yeah, Europe, yeah, yeah.
Wow. It's a worldwide issue, as you say. Um, what have we not covered? What have we missed that you
Um,
want to say?
don't think we've said it, missed anything, have we? Research futures growing.
I think for people, even if they don't feel comfortable, and I realise that it's probably a small amount of people who feel comfortable giving the heads or the HSD label. But if you're suspicious and we'll can link in the criteria, but at least direct them to someone or somewhere where you may think they might have kind of a bigger
Well,
discussion. Even
and the
just the
G,
question, have you thought about that you're quite more flexible than average? Just putting it out there.
yeah. And just make sure that you have covered the comorbidities as well, that it isn't just, they'll often have all these multi-systemic issues going on and been backwards and forwards, even from a young age. They'll have, you know, as I said at the beginning, young girls with bladder issues, allergies, fatigue. You'll
Mm,
often see that quite heavily, the fatigue.
yeah.
Um, but I mean, it's sad really because there's the GP toolkit. That was devised by Emma Raynold, Dr. Emma Raynold, who doesn't practice now,
Mm.
to help GPs diagnose it, but no one's using it.
No, no. Has it just not been put into the systems that they use? Do you know why?
I don't know. Maybe it's as well they don't feel confident and comfortable doing it.
Yeah. Leave it to rheumatology who don't want to see them.
I know.
Yeah.
And I think as physios, we're often one of the biggest professions that sees them, and
Mm.
sometimes without realizing what we're seeing
Yeah. Yeah. Yeah.
from young ages.
Well, we can mention this now. So the Heads Together is the website, right? And your PhD project's currently on that. I've got it here on the screen.
It is, yeah, Heads Together, run by Dr. Gemma Pierce, who's my director of studies. Yeah,
And
it's great.
people can get the Heads criteria either on there or if you could just type it
No,
into
so
Google,
if
can't
you're
you?
wanting to, yeah, if you were wanting to look into hypermobile Ehlos-Danlos, do you mean that, the
Yeah, yeah,
criterion?
yeah,
Yeah.
yeah, yeah, yeah.
Ehlos-Danlos Society. You've got all the criterion in there. And Ehlos-Danlos UK are brilliant. They're the ones that have raised it in Prime Minister's Question Time with regards to the upper cervical instability. But it's still a big push that for symptomatic hypermobility, in all honesty, to get the recognition.
Mm.
Um, but yeah, it's a fascinating area to be involved in.
And most importantly, I guess keep an eye out for the update next year.
Yeah,
We don't know
and
when
our
next year.
and our study, Ben.
And your study, yes, that's
Yeah,
true.
good one.
Your PhD, how many years you got left on the PhD?
So I'm on this downward trajectory. I did it 6 years part-time, self-funded.
Oh wow,
Dedication to the cause, that Ben.
that's very
And
dedicated.
so I've got 2.5 years left. So I've got one more. Well, I've just actually done a progress review panel, which I had to defend sort of my PhD. I've moved on to the next stage, and our next study is a feasibility study.
Ooh,
So we're going to be testing the
ooh.
defo.
When does the study we touched on come out?
Yeah, the survey.
Survey.
Fingers crossed the chapter's completed. The draft has gone now for our the supervisory team to look at, and then we hopefully are going to submit it to a journal that we've found, and hopefully it'll get picked up.
Mm. How long will that take once they go from acceptance to? Do we know how long?
Not long, no. Nowadays, with your open access and on straight onto the
Oh wow.
internet, they can get once they've been accepted. If there's, accepted, and then there might be revisions with it after it's been peer reviewed. But you could be. I'm hoping middle of next year it
Wow.
might be out there.
And the heads criteria update is sometime next year. We don't know exactly.
Yeah,
Yeah,
2026, they've said. I think it'll be towards the middle to the back end. They've
we'll
they've said
see.
it's the journey to 2026.
Okay. Fine.
Be interesting to see what it is.
Yeah, 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 absolutely. Anna, people can find you on LinkedIn
I am on LinkedIn.
and X, or Twitter
Yes.
as it used to be. Anywhere else?
No, no, I
No.
don't really. I'm not a big social media person, but I'm on Facebook. I'm
Facebook.
on
Okay.
I'm on Instagram. Higo Anna, I think it is, or Anna Higo.
In those
Too busy
places.
doing my PhD and running a business.
And having a massive waiting list as well. Cool. Right. I will thank you for your time. And people, I'll put in the description all the things we've mentioned about with the criteria and the websites. And then people can come find you. And like I say, we'll see next year for your paper and the new criteria.
Perfect.